Good morning. I've just seen a patient who presents with a very typical presentation of chronic low back pain, and it's somewhat disappointing and frustrating that a young fellow aged 40 should suffer low back pain and compromise his quality of life for the better part of 20 years. And so this fellow was well in 1996. He had an injury at work, a lifting injury. He sustained a disc prolapse and then went to microdiscectomy surgery in 1997. He took 12 months to recover from that surgery with what you would term standard physical rehabilitation methods through his hospital and through his surgeon's direction. After 12 months he did return to work and endured ongoing pain in his back for the subsequent 16 years, but was self-managing it with his own decisions about physical rehabilitation and medications for pain. In 2014, due to the increasing degree of low back pain, he proceeded to a spinal fusion surgery. Once again proceeded to post-operative conventional rehabilitation with a combination of physiotherapy, Pilates, hydrotherapy, manual therapy, deep tissue release, dry needling, and analgesia. His analgesic requirements did subside, and he was able to eventually obtain another job in a very low, with very low physical demands. He tolerated this job for approximately 3.5 months. Now, in 2015, after once again being out of the workforce, he engaged in further physiotherapy-directed treatment. And now he's come to see me for assessment of total and permanent disability due to him not having a future in the workforce. So his current situation is anti-inflammatories, Palexia, Lyrica, and also medications for depression and anxiety. And this fellow is 40 years old, looks fit, looks muscular and athletic, but has quite dramatic low back pain. His functional capacity is that he sleeps poorly, he can walk around comfortably, but engages in some household domestic duties. For example, vacuuming a lino floor, but not vacuuming a carpeted floor due to the increased pain that would result in. So the reason why I'm describing this story to you is that there's very strong evidence in the literature, when you look for it, that assesses the effectiveness of physical rehabilitation after surgery. And just to quote a couple of articles, there's an article by Smith et al. That reviewed 29 studies exploring the benefit of core stability exercises, mostly administered by physiotherapy or exercise physiologists. Personal trainers may engage in some core stability exercise too. But there was no evidence, there was no supporting peer-reviewed evidence that core stability exercises was any better than any other form of exercise. For example, no better than just walking, no better than hydrotherapy, no better than just normal household daily activities. There's a very good a review by author Van Middelkoop, a systematic review of randomised controlled trials in the European Spine Journal in 2011, that overall showed low evidence for all modalities of physical rehabilitation interventions in low back pain. So it begs the question as to why somebody who is obviously not getting better and who obviously has back pain, why are they continuing to engage in therapies at great expense that have no real efficacy? And we know that back pain is on the increase, low back pain is on the increase, and that may be because of increasing causation, or it may be because of decreased efficacy of treatment. So what can we do differently? And I explained to this patient that if the therapies that you're engaging in are not working, we need to consider an alternative. And at the root cause of this patient's pain is a very poor movement. Now, I've got a spine here, and I asked this patient to do a simple squat for me, and despite his huge number of physical therapy sessions, when he moved his spine, he tended to roll into kyphosis. So when he was standing upright, he maintained some neutral lordotic position. Anytime he moved into a position in front of him, he tended to kyphose his spine. And in a squat position, it was even more exaggerated. He would descend and roll into a kyphotic position, as opposed to maintaining neutral posture, descending and bending forward at the hips and maintaining that neutral position. So this is one fundamental flaw in all of the physical therapy that has been supplied to him, is the lack of attention to movement patterns. And I said to him, if you wanted to fly in a helicopter, you would not ask the pilot of a jumbo jet to take you up in a helicopter. And that's how I look at the physical therapy that's applied, is that we have physical therapists and we have movement coaches. A physical therapist may be like a jumbo jet pilot, but if the deficiency is in the movement patterns, and the movement patterns are represented by a helicopter, you need to see a helicopter pilot. And over the years, I think that has been grossly ignored in this patient, and that movement deficiency is the underlying stimulus or generator of his ongoing back problems, because there is no other explanation for the root cause of his problems. For sure, as someone endures pain for very, very long periods, there are many secondary overlaying problems, such as psychological elements, reorganisation of neural pain pathways, reorganisation in higher brain centres such as the thalamus, and those pain centres can continue to cause pain symptoms in the face of no other structural or mechanical problems. And they can continue to cause pain symptoms even if a patient is moving well. But it is still key to move well if you're going to give those abnormal central pain mediated pathways a glimmer of hope of reducing their abnormal activity. So just a story about a patient that I've seen this morning with an unfortunate story with nearly 20 years of low back pain. Thanks a lot.